So we talked initially about different kinds of formats. I mean, we know that with COVID-19, doctors and other HCPs are looking more and more to IME to get their medical education. So we talked about the use of Twitter feeds. We talked about the use of LinkedIn and really what our changing IME needs are for our HCPs. They're looking to different formats. We talked about millennials and how they often want education on the go. So it might be that they won't necessarily sit in front of their computers, but they might want to be able to pick up short bursts of education, maybe 5 minutes on their phone, perhaps between patient visits. So it's a much more fast moving way that doctors are consuming their CME. Then we talked about, how do we enhance interactivity? What kind of tools and resources should IME be providing to enhance interactivity? So we talked about some experiences of using whiteboards, and we know there are other tools that can help to facilitate that interactivity as well. And then also, how can we personalize education? We know that all our learners are not the same. So we wanted to sort of think about, how could providers think about how they can respond to the differing needs that HCPs have. And that might be because of their age, it might be where they're actually working. So really deeply understanding needs and gaps is very important because somebody working in a big academic institution may have very different needs from somebody who's in the community. So thinking about personalization and adaptive learning is really important, and changing up the formats to respond to that. We then moved on to discuss 3 very hot topics. One of them was around diversity and inclusion. The second was about including the voice of the patient in IME. And then also we talked about the impact of COVID-19 and how IME is responding to that, not just now, but going into next year as well. So starting with diversity and inclusion, we wanted to see IME that actually responds to this, that recognises these challenges. And I think, COVID-19 has really kind of emphasised, how much disparity there is in healthcare. So we would like to see IME companies responding to this, so addressing those gaps and how IME could help to provide education around addressing and meeting those gaps that are ever widening because of COVID. We also then discussed a little bit about the role we're seeing more women in healthcare. We know there's now over 50% of HCPs are now women, and how that might change in terms of that sort of addressing some of those disparity gaps. And then we moved on to talk about the voice of the patient and how important that was in perhaps changing some of the attitudinal gaps. There are certain diseases where perhaps they're not so much life-threatening, but we know they have a serious impact on not only quality of life, mental health, their social impact, and how IME providers could perhaps incorporate the voice of the patient or patients in education, which could perhaps address some of those attitudinal gaps, which could then go on to improve performance. And then finally, we talked about the impact of COVID-19 and how IME providers are responding to this. We know that it's highly unlikely that we will ever go back to exactly as we were in terms of, how people consume education. So we felt that that was really important going forwards, that we can, going back to what I was saying before about our evolving formats, how we do bite-sized education. Doctors will be traveling less to congresses, and so IME has a huge role to play in addressing that continuous need for education as the therapeutic landscape continues to evolve apace.
Fantastic. Thank you, Liz. Actually, I will ask you a follow-up question, because you're talking about sort of IME providers. Of course, so this is providers of medical education, which would include the professional providers like members of the Good CME Practice Group, but also medical societies, hospitals,
Yes.
anyone who provides education. And of course, some of the words you use there, like bite-sized learning, whiteboards, Twitter, Facebook, patients, these words don't exist in the lexicon of our accreditation bodies in Europe. So when you as a drug company look at sort of IME programs, does that mean you're not really interested in that CME accreditation part?
I think accreditation is certainly important, and in the US we know that it's essential, but I think it's not the number one driver always for physicians in terms of consuming education to ensure that it's accredited. And I know, sometimes they have to complete evaluations in order to get their CME credits, and we know that that doesn't always happen. So that would tell us that, doctors, it's not always the number one driver. So I would say accreditation is important, but it's not necessarily the most important factor. So and it's getting that education, as you say, we do partner with medical societies. We also partner with advocacy at times as well, and other bodies. So it is, as you say, a whole lexicon.